he considered, did not spend a lot of time on, is one of the things that we must all be doing as practitioners: measurement-based care. We have to measure what's happening to the child. Both, are things getting better? And are we measuring what's getting better, what's not getting better? And are we measuring on a routine basis, on a protocol basis, with some individualization, side effects that the child may or may not be experiencing? So measurement-based care is an issue that we really, something that we need to be doing a lot of. Now, one driver then is benefit to risk consideration, looking at available evidence, and then trying to individualize that particular practice, along with informed decision making. So the two big drivers, two big changes, if you will, in the practice of medicine over the past 2 to 3 decades: A, important increasing role of evidence-based medicine, which is not to say in the past doctors didn't use evidence. Of course they use data, but ultimately it was the final decision was made on the basis of their experience, not what the data ultimately said, what the evidence said. That balance has changed. And the second thing that's happened over the last 2 to 3 decades is this increased emphasis on informed decision making, on joint decision making, on informed consent. So what does all this mean in the context of policy? The proper policy perspective should be, it's not an issue of are we using too much medicine, too little medicine. When I see this kind of conversation in the press, in the legislature, or in any body, it's unfortunate, because it does little justice to the seriousness of the issue. Clearly, as a fact, there are children who are receiving medications who probably should not be, because the risk-benefit considerations suggest that there's a higher likelihood of risk, lower likelihood of benefit. At the same time, there clearly are at this time a number of children who are not receiving medication, despite the possibility that they have serious conditions that could benefit from medication with a high likelihood of benefit and a low likelihood of risk. Clearly, both are true. To say that one is a bigger problem than the other, I don't think anyone, certainly not I, can make that statement. But I know both are true. So the perspective has to be appropriate use. That is, we should pursue policies that increase the likelihood that children who can benefit from treatments, medications, psychotherapeutic medications, for example, have access to them and are able to make choices about these medications in an informed manner. So basically, the issue is not too much, too little. Should we adopt policies to drive down use, or should we adopt policies to drive up use? I think although you see a lot happening that suggests drive down, drive up, this kind of approach, and unfortunately, when you look at the tools, instruments of state policy, they tend to be somewhat blunt. Drive down, drive up, rather than, it's difficult to kind of promote this. But from our standpoint, the issue has to be appropriate use, not too much, too little. What do we mean by appropriate use? We mean it should be individualized, it should be evidence-based. We've looked at the evidence. That evidence needs to be translated into individualized treatment decision-making, to look at risk-benefit at an individualized level. It should be monitored, because there's so much variation in response. Deciding to treat or not treat is not a one-time decision. You see what happens to the child, how the child responds, and make adjustments. So you need to monitor what you need to monitor, the benefits and the side effects. It needs to be informed. It needs to be informed at the level of the clinician making those treatment choices. There needs to be informed participation by the parents. They need to have the information necessary to be making these treatment decisions. Medication should be used in conjunction with other treatments and social supports. Medications can be very effective, as we saw in Dr. Carell's presentation. But there are other interventions, other strategies that probably need to be considered in conjunction with these medications. Now, one of the things that is an unfortunate occurrence over the past decade or so is the fragmentation of care. You go to a clinic for a med check, you get a medication, you get your medications adjusted, you get therapy elsewhere, your school is providing additional counseling services elsewhere, you're getting a whole slew of services from multiple different people with not much effort at coordination of care. So when one talks about the use of psychotherapeutic medications appropriately in conjunction with other treatments and social supports, the implication is that these interventions, these strategies, will be effectively coordinated. And clearly we need a system where there are incentives to allow for promote such coordination. Ultimately, evidence very important. You can come up with guidelines all you want, very precise, somewhat loose. Ultimately, every decision to use a particular treatment and how to use it and how to monitor it is a clinical decision made between the treater and the child's representative, the parent, generally the parent, but other guardian, if you will. That's where the treatment decision is made. Every decision, the locus of decision making lies there. Now let's try and understand, define some of these terms. I mean, some of the times we use these terms and we might understand them differently. Let's try and understand briefly over the next 10 minutes what each of these terms mean. What does individualized treatment mean? What does monitored mean? What does informed mean? And then I just want to share with you a couple of things that are happening at the state level with regards to translating what seems reasonable into actual practice, and then we'll engage in a conversation after that. What is individualized treatment? Well, individualized treatment actually begins with individualized assessment. What's happening to the child? The child is not aggressive behavior, mood instability. Well, what's the context? You need a comprehensive assessment, which includes a comprehensive biological and psychological assessment. Individualized diagnostic and social formulation. What's happening to this child? A diagnosis is important, but it gives you only part of the picture. Why is this child having problems now? And you need an individualized formulation. And if I use, the idea is, if you're thinking of a particular treatment, you first need to understand the problem. And if you're going to use a particular treatment, you need to be able to say, if I treat, I expect a change in this. I'm going to measure this, whatever that this is. This needs changing. I think this particular treatment will change this, and I'm going to measure how this is changing or not changing. And I will make adjustments in treatment based on whether this, whatever that this is changing or not changing. And that this is not the diagnosis. That this is the formulation, based on the formulation for this particular child. And you've got to think about, in your assessment, in this child, what are the particular vulnerabilities? Is there a family history of diabetes? That alters risk-benefit considerations. Are there certain specific circumstances in this child that need to be considered as I think about this child's risk-benefit profile, if you will? So individualized treatment is not just a DSM diagnosis. It's much more than that, and it needs to be individualized. Then you think about treatment. Okay, you decide, you've done a comprehensive formulation. The next step is, well, there is this in this child which needs changing, which is interfering with the child's development, which is interfering with this child's adjustment. This needs changing, and I am thinking about this treatment X to change this. I need to have a specific target of treatment that's clearly defined. What is this? And it should be measurable. Frequency of aggressive behavior, mood instability as reflected in these particular behaviors in this child. This is what I expect changing. So we need a specifically defined target of treatment. Whatever treatment choices I make should be evidence-based. It's not a hunch that I have.